Okay. This is a 70 years old patient referred because he is suffering from jaundice and the alkaline phosphatase is raised markedly. Is 1041. Normal should not raise to 79 by the lab normal parameters. So significantly raised alkaline phosphatase, and with the jaundice, direct bilirubin is raised in this 70 years old patient. So I am going to start the scan by in a standing posture. The reason being the viscera will come down and make my life easier for ultrasound, because when I first scanned this patient in supine and left lateral decubitus posture, I did saw a gallbladder pathology with ascites. However, I was unable to get the pancreas, which is the most important organ to be visualized in such cases. So in case if you are not getting the gallbladder or the other common bile duct in supine or in left lateral decubitus posture, if the patient can stand up and stand for a while, scan in this posture so that you can get a better idea when the organs come down, regarding all the organs in this region and vessels as well. So after image optimization, I started the ultrasound and placed the probe in the epigastric region to see if there is any porta-hepatic region pathology or common, what is the status of the common bile duct. Now this is the region of the porta hepatis. Here we are, and a tiny cystic area seen anterior to it. This one is the common bile duct in transverse section. This is the inferior vena cava. This is the portal vein. This is the common bile duct in transverse section. Measures 5.6 and is not dilated. Up to 7 is considered to be as normal. Now you see that when I go transversely and try to get the pancreas, I am getting the pancreas by its landmarks as well as known texture. As the age advances, we know that the pancreas goes fatty, but in this case I am not seeing a fatty pancreas. If this is the pancreas, now this is the pancreas, body of the pancreas, this area. Okay. This is the superior mesenteric vein, this is the splenic vein, this is and now if you see this tiny structure, anechoic tubular, is basic, in fact the pancreatic duct, which is not dilated. So this was our portal vein. This is the CBD, common bile duct in transverse section. This is the liver, left lobe. This is the body of the pancreas in transverse section, and the D is basically for the duct, which is not dilated at all. This is the superior mesenteric artery. Okay. This vessel is splenic vein. Now the portal vein is normal in diameter and is not dilated, is patent. This is the portal vein. It measures at the region of the porta hepatis from inner to inner 8.0 millimeters up to 30 is considered to be normal. Now, in the same view, I am able to get the head of the pancreas with the duct. Now, this is the head of the pancreas, the encircled area. This is the head of the pancreas in longitudinal section. This is the transverse of the body of the pancreas. However, as you can see, this is the tail of the pancreas, this area. There is no lymph node seen, however, at the region of the porta hepatis. So this is the head of the pancreas. Head of pancreas. Now, and this central dot, cystic dot that you are seeing is in fact the duct, the pancreatic duct, this area. D stands for duct. Here, this is the duct. So there is no pathology related to the pancreas. The pancreas is not, there is no evidence of pancreatitis, no focal mass lesion. The dimensions are normal and the echogenicity is normal. The duct is not dilated. So pancreas is normal. This rules out any pancreatic pathology as a cause of the lab findings and the patient's clinical picture. Now, after seeing this, that there is no lymph node seen at the region of the porta hepatis, let's see if there is any in the let's proceed further and see that if what is the status of the liver. Are the bile ducts dilated? Intrahepatic bile ducts. We have seen that the common bile duct is not dilated. The common hepatic duct is not dilated. Now this is an area that gives you an impression of this is the, sorry, because of some gain problem. This is the portal vein. This one, this is the common bile duct, and this is the hepatic artery in transverse section at the region of the porta hepatis. Here, let's see the left lobe of the liver. Here we are. So, up to, yes, there is mild intrahepatic bile duct ectasia. Here you see, this is the ascending portion of the left portal vein, and this is the posterior branch, left posterior branch entering the ascending portion of the left portal vein. This is the left ascending branch, this is the right branch, and this is the ligamentum venosum, this is the caudate lobe. So there is no focal lesion in the liver. The ecotexture of the liver is slightly decreased because the periportal echoes are seen raised. So slightly decreased parenchymal echogenicity of the liver with homogeneous texture. This is the outer surface of the liver, which is smooth and regular. So there is, in fact, there is no significant intrahepatic bile duct ectasia seen so far. Now let's see the branches of the portal vein, because you know that the common bile duct and its branches run parallel to the portal vein throughout the liver. So there is no evidence of intrahepatic bile duct ectasia. So what is the reason then? Now come to the gallbladder. This is the gallbladder. You can see this well defined. This is the wall of the gallbladder. Internally it is filled with different strength internal echoes, full of sludge rather. The wall is regular. The wall is not thick. Measures 2.3 up to 3 is considered to be normal. Now this was the transverse section, and if you see that this gallbladder is surrounded by a loculated fluid pocket. Yeah, the gallbladder in fact is not seen. Now is it gallbladder? Is a question to be asked. Must ask yourself, is it the gallbladder or something else? Now if the portal vein is seen at right angle to its neck region, then this is the portal, then this is the gallbladder. Otherwise it is not the gallbladder. It may be some other pathology. So we will come back to that area to see that area. You can see that here this area that I am saying you is the gallbladder is filled with now these are cholesterol calculi, these tiny. These are cholesterol calculi, the reason being that they are giving short comet tail artifact. This is a short comet tail artifact. This is a short comet tail artifact. This is an artifact. Now this is a loculated fluid pocket around this gallbladder that measures, come on, and this is the fluid pocket. Note that in this fluid pocket there are multiple septas. This is a thick septa, incomplete. This is fluid. This is all fluid. This is debris within the fluid. This is clear fluid, all black. This is fluid with debris. You can see slight echogenicities and sand-like particles. These are thin septas. This is a septa. So the multiple septa are radiating from the wall of the gallbladder, and they extend up to the margin of this loculated fluid pocket that is also infective in nature by sonographic parameters. Liturgical. Now I'm going to scan the patient in lying posture, in supine posture, and in left lateral decubitus posture, after having seen studying the cause of the obstructive jaundice. Okay, we'll come back to the common bile duct, the gallbladder, and first of all I will define with patient in supine posture that where is the portal vein, what is the relation of the cystic area filled with echoes with the portal vein, and here you see that this is the portal vein, this is the gallbladder with, now this is the cholesterol calculi. Note the comet tail artifact. This is the gallbladder, this is the portal vein, and it is at right angle to the neck of the gallbladder. This is the neck of the gallbladder, this area. So we are seeing the gallbladder, no question about that. We are right in this sense. Now this fluid pocket is seen extending into the, it does not cross the midline, Now this fluid pocket is rather extending into the lesser sac. So you see that this is the gallbladder. Anterior portion is rather a bit clear. The appendant region full of different strengths internal echoes. This is the wall. This is the loculated fluid pocket. This is the wall, and these are the septa within the cystic area, loculated cystic area that is extending into the lesser sac. And it is infective in nature. You can see that these are the debris. This bright area are all sand-like particles. Anterior portion is clear, thin septa. This is thin incomplete septa, thick septa. This is thick complete septa. So the look of this fluid pocket is that of it being infective in nature. Infective. So we see the gallbladder, which is surrounded by a fluid pocket that extends into the lesser sac. And another finding, is there any other finding? Yes, here we see fluid in the hepatorenal angle. This is the liver. This is the right kidney. And this area, this black area is the fluid between the liver and the right kidney. So this is fluid in the hepatorenal angle / Morrison's pouch. I would like to see if what is the status of the liver while the patient lying in the supine posture. This is we can see, I want to see the hepatic veins as well. The IVC. Now this is the inferior vena cava. Here, this one. This is the IVC, curved vessel. This is the aorta. And there is no evidence of aortic flank adenopathy. This is the left lobe of the liver. In longitudinal, this is the left lobe in transverse section. You can see the hepatic veins as well. So far there is no evidence of any intrahepatic bile duct dilation. However, you can see that this is the fluid in the Morrison's pouch. This is gallbladder. This is the fluid pocket. Now these are bowels. This is the fluid. This is the right kidney. So this is the fluid in the Morrison's pouch. So the kidney is normal. No evidence of pleural effusion, right pleural effusion. Now this is the portal vein dividing into anterior posterior branches. This is the right portal vein. Here we are seeing the right lobe of the liver in total. Here we are seeing the left lobe of the liver in total. This is the right hepatic vein entering the IVC. The IVC is not dilated. In blood carrier syndrome, you will see that the IVC will not be, and the hepatic veins will be obscured. Let's see the spleen. Now this is the spleen. This is the left hemidiaphragm, no pleural effusion. Spleen measures 7.8. is with a normal dimension. This is the left kidney. Passa mere left. Okay, now this is the left kidney and is normal by all parameters, but there is fluid between suprenorenal angle and this is the ascitic fluid. No purification seen. This is the spleen and this is the upper port of the left kidney. This black area is the ascitic fluid. This area, this is the diaphragm. So let's go to the pelvic region, and you can see that there is this is the urinary bladder. This is the urinary bladder in transverse section. This is the prostate, normal in size, and here you see that there is fluid in the pelvic cavity dependent region with the bowel segments floating in it. These are all bowels. These are all bowels, and this is the ascitic fluid. This is the fluid. This black area, total black area. So there is ascites in the dependent region peritoneal cavity. These are the ionic vessels. Okay, let's see if there is any abdominal pathology, bowel related pathology or not. We give a sweep in all of the abdominal quadrants to rule out any evidence of some bowel related pathology. There is the pathology on the right side. There is no bowel related mass that we are seeing. This is the same with now this region is, this one is the urinary bladder. Okay, now coming back to the no intrahepatic bile duct dilation, no common bile duct dilation, liver otherwise normal by all parameters. Now this so this is our case. In fact, what's happened is that there is gallbladder full of, almost full of internal lactose, and it's surrounded by, this is the gallbladder, and these are this is the sludge. This is the wall of the gallbladder, which is not thick, and this is the fluid pocket with septations within it. This is the bowel. These are the bowels. This is the right kidney in transverse section, this area. And this black area is all fluid in the Morrison's pouch, fluid in the Morrison's pouch. This is the loculated fluid pocket. So, in fact, the pathology relates basically to the gallbladder and the loculated fluid pocket around it, the cause of jaundice and all the other findings that we are seeing. Now, this is all what we can provide by ultrasound. And in this case, CT scan with contrast is ideally recommended. Thank you.